Hello, everyone, and welcome to another Northeast Georgia Health System DEI podcast. Today, we are focusing on maternal fetal health and disparities in that area. I'm Dr. David. I'm one of the associate program directors for the family medicine program and the interim director for the transitional year program. And today, I have with us Dr. Parker and Dr. Tembele, and I'll let them introduce themselves. Dr. Parker.
Hello, Dr. David. Thank you for having me today. I am a board-certified family medicine physician who I also completed a one-year maternal child health fellowship. So I focus a lot on women's health, obstetrics. I still deliver babies and some gynecological procedures as well. And then I still also serve as family medicine faculty for our residency here in Gainesville.
Thank you.
Hi, everybody. My name is Tembele Yangandawele. I'm also a board-certified family medicine physician who also did a fellowship in maternal fetal health over in West Virginia University. And also work with Dr. Parker here with our resident. The fellowship allows us, of course, to do some OB/GYN as well as GYN procedures and management for per se. And I'm glad to be here.
Okay, awesome. Thank you both for being here. So first, I just want to get into like the state of affairs and just go through some numbers, tell us a little bit about where we are. This is from the March of Dimes 2023 report. The preterm birth rate in Gainesville, Georgia in 2022 was 11.9. That was a F grade. For the national preterm birth rate, it was 10.4, which was a D+. And the preterm birth rate for blacks in Georgia is 1.5 times the national average. Related to that, the U.S. infant mortality rate is 5.4. The Georgia infant mortality rate is 6.3. And the rate for blacks in Georgia is 9.5, again, about 1.5 times the state average. And then finally, the U.S. maternal mortality rate is about 32.9, and the rate for blacks is about 69.9. So again, significantly worse there. So I just want to get your initial thoughts on some of those disparities related to maternal and fetal health.
I think saddening is the reaction when you hear those numbers. Yes, because indeed we are not doing as good as we could possibly do. Of course, it's a daunting task to be able to, in the blink of an eye, be able to revert some of those trends. But I hope that this podcast can kind of at least shed some light on the reality of our state, and hopefully start the conversation.
Mm-hmm.
Yeah.
Okay, thank you. One of the main things related to infant mortality is preterm birth and low birth weight, and some of those factors related to that include access to health care in general, as well as access to health care while pregnant. Mm-hmm. So access is one of those factors that I think we have to look at to try to make a change in some of those rates. Do you have any thoughts about access and things we can do?
Pretty sure you guys are aware that we do have a lot of county that are shutting down the OB/GYN services, actually not GYN but the obstetric services, just because of the lack of financial backing behind obstetrical care. So I think that's one of the biggest piece of the puzzle. I feel like, of course, we need to do some work that needs to be done as far as providers and so forth. But I feel like it's hard to deliver without a facility that's gonna accommodate those services per se. So for me, I think one thing we need to really start to focus on is actually looking into how do we make Medicare and Medicaid kind of sustainable when it comes to obstetrical care, and really putting some value behind female health and obstetrical health per se, to kind of help to kind of cover those voids and stuff. Because there are studies indeed that show that the farther out those women have to travel, the higher the risk for adverse outcome for the mom and the baby. So really narrowing down that distance of traveling for those pregnant patients is bound to yield a lot more results than what we're doing right now.
Okay.
And on a larger scale, of course, we want more access to healthcare in some of these more rural communities. But even just socioeconomic factors for moms, who may live in urban areas but may lack access to either public transportation or funding for ride sharing if they don't have any transportation. And then childcare is an issue as well. So if there's multiple children at home, and an OB office may limit to a baby or, 2 kids or no kids at all, that also puts stress on the mother of where her other children are going to go, to how to get to her appointments, or, if that OB provider is going to allow her to bring her other children, or, payment plans of getting discharged if they don't pay their deductible on time. So the rural communities, it is where we see a lot of this disproportionate care, but also if you think in our urban areas as well, there are also many factors that may limit a mom being able to get to her OB provider, or, and speaking of infant mortality, a pediatrician as well.
Okay.
Yeah, just to piggyback on that, I can give myself as an example. I live in Brazelton, which is not really considered a rural area, but we still had to drive all the way down to Gainesville to kind of see our MFM, which kind of just show that. And that's no patient that are driving 45, 50 minutes an hour to see the MFM, because that's the only one that we have in the area. So and those people are quite urban. I would consider them, they're quite doing well, but yet we still have those limitations that we are plagued with and that we have to work with. So just imagine some of our population that are a little bit more dealing with a lot more challenges when they come to the financial challenges and socioeconomical challenges that they may face. How difficult that will be. I can afford a babysitter to kind of watch my 3-year-old, 2-year-old daughter while my wife's coming to the visit and I'm at work. They may not be able to do so. So those are all socioeconomical factors that really plays a big part into what we are seeing as a result of, and we really need to start taking all of those into consideration per se.
Thanks for that. Now, MFM, that's a maternal fetal medicine specialist.
Correct.
And they are mainly involved with high-risk
Correct.
pregnancies?
So my wife was pregnant with twins, so definitely the goal is to just kind of help us manage our pregnant patient when those that are considered high risk, per se. Yeah.
Okay. What other things are considered high risk that you would need a MFM specialist?
So if you think of our kind of standard, what you hear in the population, high blood pressure during pregnancy, diabetes requiring medicine during pregnancy, like Dr. Tembele has experienced a pregnancy of multiple gestations. So if there's more than one baby, we definitely want them to see MFM. Any kind of heart disease, kidney disease, autoimmune diseases, or just anything, where as general practitioners, if we feel like maybe a patient may be sicker or their pregnancy may be more high risk, it's always nice to have the maternal fetal medicine specialists to, give them a look over to make sure that there's nothing that we're missing.
Okay, great. So sounds like a couple of things there. One is access in general, and then even more of a potential issue is access when you need a specialist beyond just OB. So if there is an issue with that in a relatively suburban setting, I would say, and not a rural setting, I would imagine it's even more of an issue in the rural setting. So that would be a major potential issue. What can we do to address that? Are there some thoughts you have that may be able to improve access for those in those scenarios?
I think, getting providers to that area is important. Incentivizing those providers to maybe go out to those further areas. And then also, I think, kind of getting a little bit more creative in how we reach those patients. So, a patient with hypertension, if she has a smartphone and can do a telemedicine visit maybe, and speak with their provider on giving blood pressure logs or sugar, glucose logs. I think that can, really help. We can really empower some of these women to kind of help us do some of their care if we use our audiovisual technology or, the great internet in working with them when we can't get the physical providers to those areas. I think that's one way that we may be able to help.
Okay.
Absolutely. And the other thing also I can think of on top of my head, like with working with the residency program per se, is really trying to inspire some of those young residents as they're going through their training to kind of embrace the OB realm as well. Because, there's only so much that our OBGYN providers can do, and almost so many of them out there. So one thing we can do to really kind of fill that void is to increase the number of FM providers that are able to do obstetrical care. Therefore, also finding a way to exponentially increase the number of providers in that sense. Of course, leaning on our OB for the very more complex cases, but I believe like some of them and using our FM provider as almost like a triage per se to kind of funnel, like, okay, we think we can take care of you here, you a little bit more higher level or need a little higher level of care. Let's go ahead and have you plug you in with this OB provider where I can kind of serve as a satellite for the OB provider. So really, I think Dr. Parker said it well, really rethinking about how we provide OB care in a sense and really trying to work with some of the technology that we have at hand and the system and that we have at hand.
Okay, so one possibility is increasing the number of providers able to give that care, and there is OB fellowships. There are OB fellowships where family medicine docs can go into and take care of those patients that are low risk to average risk, and that would supplement the shortage, generally speaking, of OB doctors, especially in rural areas. So I think that sounds like a great avenue. One thing that you touched on earlier, you mentioned about Medicaid, Medicare, and some of the possibilities that may lie there. I think one thing that I was looking at was Medicaid expansion, and so not every state has expanded what they offer in Medicaid relating to OB care. Can you touch on that a little bit more detailed?
Absolutely. I mean, we tend to think about, obstetrical care just from the moment the woman gets pregnant until she delivers. Well, that period actually extends beyond and goes usually what I consider at least a year after she delivers. So that's very important because, we have that time frame where we're able to monitor those women and follow them. Those that had elevated blood pressure, they're still doing good. Those that had elevated glucose tolerance tests, are they developing any diabetes? So there's a lot of follow through that needs to be taken care of. And not only that also provides us with point of contact to check on those patients' well-being and check on the baby and so forth. But when those options from an insurance standpoint are not available, we are not able to have an eye on those patients. So what they ended up doing, they deliver, they get the baby, then leave. There's still some adverse outcome they can possibly, God forbid, can possibly happen, develop during that postpartum phase as well. So really working hard in that sense, I think it's very important.
And as family medicine doctors, we really fight for that because the great thing about the path that we chose is that we get to see the babies along with their mothers. So, we know that it's more likely for a mom to take care of herself when she's also bringing the baby to the appointment. So we'll try to schedule our postpartum appointments together with the newborn appointments to try to make sure that we're checking on mom too. However, when you have moms that say like, oh, my Medicaid ended, am I going to have a copay, but the baby's not, then that also puts you in a bind as a provider of caring for this patient because she's telling you financially. And then that's, more paperwork of sending mom maybe to a different doctor or to a free clinic. So it's really important that we understand that postpartum care, like Dr. Tembele said, goes beyond the year, or I'm sorry, at least up to a year, I think beyond a year, but at least within a year postpartum, so we can really make sure that some of these moms are taken care of that have these medical issues during pregnancy.
One thing that also actually just come in mind is the notion of family planning too. We do have a lot of very young teenage moms and so forth. So that expansion is able to give us opportunity to expand on those things because the evidence does show it. The outcome when it comes to social economical outcome for those moms seem to just continue to deteriorate if they were to become pregnant again. So in the ability to have that visit where we can actually provide some type of contraceptive cares per se for those moms, allowing them not only to take care of the baby, but also not running the risk of becoming pregnant again 8 months, 9 months after they just deliver, and just drastically changing the trajectory of their life is important. So there's all those multiple facets to this conversation that we are able to address if the funding was behind it, that right now we are not able. I find myself multiple times really trying to push for that, birth control and contraception in the postpartum phase when they're still in hospital, which I'm thinking of all that. I'm thinking
ahead.
It's going to be covered when they get out
once
the
you
hospital.
leave here, it's not going to be
Am I gonna
covered.
be
So
seeing you?
and you're 17, you just had a baby. I want to make sure that you have the time for your body to rest and also to kind of taking care of yourself and taking care of this new life that you just brought to life, as opposed to seeing you in 10, 12 months later.
Right.